Hello and welcome to the Doctor's Corner. I'm your host as always, Dr. Mark Pinsky, and today we're doing skin care, skin cancer, everything you want to know about skin 101 with Jennifer Hanley. Jennifer is from Hanley Skin and Cancer Center, and she's going to talk to us about all these great skin tips. Right, Jen?
Sure.
All right, welcome to the show, Jen.
Thank you for having me.
All right. So tell us how the center got started, because I think that's kind of an interesting, neat story.
Okay, so my husband, who is a board-certified general surgeon, has been practicing for over 20 years. And
My partner, brother.
Okay. He's the man behind the man. So he actually has always treated skin cancer as it's a part of all general surgical practices. And I have been a PA for a physician assistant for over 20 years. And for the last 14 years, I've been specializing in skin cancer. And so in 2013, we decided to coordinate our efforts and start the Hanley Skin Cancer Center.
And I'm really happy about that because I talk to Jen all the time and she's pretty terrific, and I'm a little biased here. But, you know, when you can send person pictures at 7 o'clock in the morning and they respond to you, that's always a good thing. And I do it. That's always a good thing. So let's get to it. Let's talk a little bit about who really should be screened for skin cancer.
Okay, well, 1 in 5 Americans will get skin cancer in their lifetime. So it really affects people of all races and colors. And so really, that means pretty much anyone's a candidate for a skin cancer screening.
So what age should we start doing that?
It really depends. That's a good question. It depends if you have a family history of specifically melanoma. Or if you have greater than 50 moles. And so I would say that age could just depend on you personally. Okay. And usually people start to see me when they start to notice sun damage. Right. But I do see children that have genetically have a lot of moles. So.
Okay, so even kids, again, so Absolutely. If they have a lot of moles, Jen recommends that those people be screened Absolutely. As well. Let's say I'm somebody in my mid-20s, but I've never had any issues, but there's a family history.
If you have a family history of melanoma and you don't have a lot of moles, then you really can just have your primary doctor do a screening every year. And the most important thing is you should be doing self-screenings. That is a huge benefit for you because even if you saw your doctor once a year, you know, something could change in that time, so you might not be aware. And melanoma is the most deadly form of skin cancer. And in that year's time, that could be, change your diagnosis if you're not checking yourself.
Okay, so let's talk about looking at your own skin at home.
Okay.
And let's talk about what you should do to try to figure out, do I need to see Jen? Do I not need to see Jen? You know, talk to me about that.
That's a good question, especially when I see people who have a lot of moles or a lot of freckles and they sort of just don't know what they're looking for. So I tell people you're looking for an ugly duckling mole, and that basically means something that's different from the other moles. Or you probably heard of the ABCDEs of moles or of melanoma.
I have.
And so what that stands for is A is for asymmetry, B is for borders, C is color, and D is diameter, and E is evolution. So basically, if your mole is changing in size, shape, color, border, any kind of symptoms of mole, then it probably should be addressed.
Right, so that's usually what happens. They come to see me, and there's usually some type of irregularity. I have noticed a change over this time. Right, so every once in a while I get somebody, I don't really know how this happens. Dr. Pinsky, I don't know how long it's been there.
That's
I have
pretty
no
common.
idea. Right. So then those people, you obviously can't do that. But I still tell them, I do tell them, you got to do your A, B, C, D, E's. And it's really pretty easy to remember. And so I have them go through all of that with me, even in my office. So A, B, C, D, E is super duper important.
Right. Okay. Another thing you can do if you have a lot of moles, you're never going to remember every single mole you have. So I tell people to photo document their moles, especially now with cell phones. I mean, it's so easy. Just take pictures. Have someone take a picture of your back if you have a lot of moles, and then you can compare them. It's just really easy.
I never did that. That's actually a good idea. See that? See? Jen. All right,
Let's talk about the different
types of skin cancer.
Okay.
So you already mentioned that melanoma is the most deadly.
Right.
Is melanoma is the least common, correct?
It's the least common.
Right.
Basal cell and squamous cell are the most common. And there is a 95% cure rate, I'd say, if detected early. Melanoma, it can have a cure rate if you're checking yourself and it's detected early. But otherwise, it can, with advanced disease, it can...
Yeah, really be deadly. I've had a couple of real tragic stories with my own patients, really. So I want you to be diligent about that, because I think it's super important that we live down in the sun capital of the world, and we're grateful for that.
Absolutely.
But with that comes responsibility. And so I do tell the patients, you got to take care of your children. We're going to talk about sunscreen here in a second. Okay. But one of the big things I tell them is when you're looking at yourself, if you can't, it's hard to see your back. Right. So have somebody else, take a look at you. And I do agree with you. Documenting by pictures is a great thing in this modern era. And do it on a regular basis, because we often don't pay much attention to that kind of thing. And it really is devastating. I've had patients where the actual primary was never found. Yeah. Right. And that's really tough. It was really, really tough. But in that case, like every case, he did not have very frequent exams. Right. Despite the fact that we talked about it all the time, it's very important that not just somebody like me see it, but somebody who specializes like Jen does, because she will see things way different than I see them, and she definitely will see things way different than you see them. So it's super duper important that we stay very diligent about that and stay caught up. Let's talk about a little bit about basal cell and squamous cell, because I think squamous cell not as much, but basal cell is pretty distinct, right? A lot of the times you can kind of recognize a basal cell. I try to describe it as, it doesn't really look like a normal thing, but it usually has some type of color to it, right? It's got some kind of pink pigmentation to it.
Sometimes, you'll hear the term pearly. Right. It's a shiny papule. I usually tell people if they have something that looks like a pimple, that doesn't go away, because pimples go away. So if you have a pimple that doesn't go away after 4 weeks, it's most likely not a pimple. It doesn't mean it's a skin cancer, but it probably should be checked out. Right.
And so some of my older folks, one of the things they talk about all the time is they get these little things and they just pick them off. And then they go, oh, they went away. I just picked them off. So they're gone. They're not gone. So you still have to see somebody who's actually going to treat them, because all you've done is taken off the superficial part. Those are actinic keratosis, most likely. And those are precancerous lesions for squamous cell, correct?
Right. In a small percentage of time, an actinic keratosis, which is a precancer, can turn into a squamous cell. And they're easily treated with cryotherapy or topical therapies. So if you're not sure and something doesn't go away, you should get it addressed. I always tell people, bad things don't go away. Correct. So, when I see patients and they say, I had this spot, but it went away, so now I don't. And I say, well, then it was probably fine.
Right. So I still think, again, every year, I'm a big, huge proponent. Every year I'm due for my test, so you're going to get a call. But the bottom line is you really should be screened every year. I do think it's incredibly important to do. If you're high risk, every 6 months. And, of course, Jen makes that call depending upon what she sees.
There's different criteria.
Right. And I you don't need to go through the criteria for those guys. But the bottom line is, skin cancer in and of itself can be deadly. We need to treat it like a disease that it is. And we need to recognize that not every skin cancer is equal to one another.
Absolutely.
So if you don't see something go away that hasn't been there before or is changing over time, then you need to see her.
Absolutely. I'd rather see someone and tell them it's nothing and they go about their day than them just put it off and it's too late.
All right, let's talk about the treatments for different skin cancers, because you kind of highlighted a little bit. Okay. Let's just do basal cell first. And then we'll
well, I classify basal cell and squamous cell together as non-melanoma skin cancers. Okay. So basically, they're the standard of care is surgical excision. And if detected early, it's a small lesion. It's usually easily treated in the office, and it's a simple procedure, not a huge deal, and 95% cure rate. Right. Melanoma's different.
Right. So let me just go back to that.
Okay.
Is the only time you really use cryotherapy, because I know you'll do cryotherapy even on some basal cells too.
I will
so
sometimes.
How do you make that decision whether you're going to do cryotherapy, which is just a freezing?
Right.
I want to make that clear. It's just almost everybody out there kind of knows because almost everybody's been zapped. Me included. So what makes your decision on whether you freeze it or whether you're going to actually cut it?
Well, excision is standard of care for the deeper basal cells. Okay. So a superficial basal cell that's just a basal cell that's on the top layer of the skin. That can be treated with something called electrodesiccation and curettage, or it can be treated with cryotherapy, or it can be treated with a topical cream.
Okay.
And also, I make decision based on patients' age and comorbidities. Okay. So a basal cell is a very slow-growing type of skin cancer. If I see a patient who has multiple medical problems and isn't really a candidate to undergo surgery, I may consider cryotherapy, but those are all secondary considerations.
Okay. So primary is still surgical.
Is still surgical.
And I do want to give a little warning out there, to be honest with you. I've seen some basal cells, if you just ignore them, there's local destruction. I don't want to get the impression that a basal cell is this benign thing that's just a simple cancer that goes away. It doesn't, and it creates a lot of local destruction. It needs to be treated, we should treat it appropriately. And of course, I let the professionals decide what that is.
Yeah, it definitely needs to be treated, especially in cosmetically sensitive areas. And I don't mean for aesthetics, but simply for lack of tissue. Yeah. So.
And I've seen, and Mark deals with this all the time, it becomes very difficult to create a very good cosmetic result, is what I think Jen's getting at, without creating disfiguring just based upon where the cancer lies.
Right.
And I've seen some tragic results. Okay, so squamous cell, basal cell we already covered. Melanoma. Let's do melanoma now. What's some of the crazy criteria for melanoma?
So in terms of, if melanoma is detected early, and we call that stage 0 or in situ, then it's actually curable. We treat it in the office with a wide local excision, and you have a 100% cure rate. Stage 2 through 4, then it really just depends at the time. Your 5-year survival rate depends on the staging at the time of diagnosis.
Does that go by the depth of the...
It does. Okay. It goes by the depth, and also with that, there's also local lymph nodes or distant metastasis. Right. So the stage varies based on that, and your survival varies based on that.
So take-home message... Don't let it get too far.
Absolutely.
See your professionals, self-diagnosis, right? Do your self-assessments is what I was trying to say. And then make sure that you follow up with a professional. All right, let's talk about trying to prevent skin cancer.
Okay.
All right, that's everybody's goal. That is the Pinsky way. We are trying to prevent all diseases, stamp out disease, pestilence, sorrow, strife. That's what we do. Anyway, let's talk about how to prevent skin cancer.
Oh, no. The biggest thing is avoiding UVA rays, UVB rays. I
obviously do that, Jen.
Well, that's good.
I do.
It's good for prevention of skin cancer. It's good for prevention of aging. Right. So there's lots of benefits for that.
All right. Now, let's talk about the different types of lotions and creams and all that, which really blows everybody away because if you go to the store...
Very confusing.
It is. You go to the store, you look on the shelf, there's 5, 10, 15, 30, 54, 67, 93.
Even I'm confused sometimes when I go there. I mean, I'm not really, but there's so many.
Yeah.
How do you know? Yeah. So my biggest thing that I tell patients is the best sunscreen that you can use is the one that you use. So if you're not using it, it's no good.
Right. Simplify. I like it.
And then if you want to get technical, there are more specifics. Right. And so you want to try to have a sunscreen that's SPF 30 or higher. And the whole SPF thing to me is a little bit tricky. So it stands for sun protection factor. And basically what it means is it's the time that you would burn if you were protected if you weren't protected versus the time that you would burn if you were protected. And so that can be different for different skin types. So if you burn in 10 minutes in the sun, and you wear an SPF 15, then it's going to be 150 minutes of protection when you wear SPF 15.
Didn't know that, see?
But if I burn in 20 minutes, then it's going to be 300 minutes. So with all of that, I find it to be sort of irrelevant. I think you should just reapply every 2 hours.
Okay. And all that waterproofing stuff, is that like real?
No, it is real. You should look for a water-resistant sunscreen, ideally. However, after the water or sweating, you should reapply.
Right. Okay.
You should reapply.
Do I need to do something separate to protect this ugly mug, or am I okay with this ugly mug using the same stuff as the body?
Again, the best sunscreen that you can use is the one that you use.
I'm going to use it, but my question...
There are sunscreens that are more elegant for the face. Right. Definitely. They're non-comedogenic, which means they don't clog your pores.
Right.
And I really say if you're going to be out in the sun for more than 20 minutes, you need to put on SPF 30 or higher. And when you get home, you should wash it off.
Okay. That was my next question.
You should wash it off when you get home. Yeah.
Okay. Excellent. What else? What else did we cover? Because that SPF thing really does freak me out.
It's very confusing. Yeah. So I give people just the general rule of thumb. Don't worry about it. Just get 30 or higher and reapply every 2 hours or after the water or sweating.
Right. So that likes like 97% of the rays, right? It's greater than 30?
So SPF 30 or higher is 97%. Yeah. And the reason why it doesn't really matter if you get higher is because it's not exponentially better. Yeah. So at SPF 15, you got 93%. At SPF 30, you get 97%. So there is a big jump there. Right. But at SPF 50, it's 98%. SPF 100, it's 99%.
And the price jumps ridiculous.
So you still need to reapply. That's the key.
Here's one thing. You started to talk about the pigment of the skin, which I think is really, really important. So there's this notion out there, if I'm already tan or if I have dark pigmented skin, that I don't need to do anything. Please dispel the notion, Jen.
No tan is a good tan.
There you go.
No tan is a good tan. So tanning is typically from the UVA rays, which are the longer rays that actually get into the dermal layer of the skin and cause those brown sunspots and wrinkles. And so any tan is basically damage to the DNA of the cell. So... and it's thought that the earlier you get sunburns or blistering sunburns, the higher chance you have of getting skin cancer, because that's just longer time for the DNA to mutate and change into skin cancer. So really protect your kids.
Okay, terrific. Listen, these are all good clues. If we give you too much information, we'll bring Jen back because we got a lot of information to talk about the skin. In any event, Jen, I really appreciate you being here.
Anytime.
Thank you so much for coming. For Jen Hanley, I am Dr. Mark Pinsky. You've been watching The Doctor's Corner.
Thank you.
This is Dr. Mark Pinsky once again, asking you to forward questions to us, whether regarding this episode or any of our past episodes, at drmarkscorner@gmail.com. Also, don't forget to check us out on our website, pinskywellness.com or pinskyweightloss.com. We look forward to hearing all of your questions, and we'll get back to you as soon as we do. Y'all have a great week.